Good evening, everyone. Today's topic in our emergency series of webinars is Journal Club. In this, we'll be discussing about 3 studies. So, arrest trial, and then the inception trial. So, we have 3 team study from Yashoda group of hospitals, each from one of the branches. For the first study, will be discussed by Dr. Aleem Syed and team, the speaker being Pooja. Dr. Aleem, are you ready?
Sir will be here in 5 minutes.
Okay, you can start presenting.
Okay. Here.
Ever since ECMO, the COVID came in, the ECMO has got into usage much more, and recently almost every hospital is capable of doing ECMOs. So in this, so we thought it would be a nice topic to present, to get in touch with the current modalities and what's going on, what's new in this ECMO. So the first study is by the Secunderabad team, that is Dr. Pooja will be presenting now.
Sir, I have PPT sharing the converting the visible option the parallel.
Yeah, your PPT is visible. Please go ahead.
Okay, sure. Okay, good evening, everyone. Today in this session of Journal Club, we'll be discussing about arrest trial. Basically, advanced reperfusion strategies for patients with out-of-hospital cardiac arrest and refractory ventricular fibrillation. Usually, out-of-hospital cardiac arrest, it is responsible for more than 350,000 deaths each year in North America. And most of the patients surviving out-of-hospital cardiac arrest, they usually present with an initial shockable rhythm of ventricular fibrillation or pulseless ventricular tachycardia. And among these patients, half of these patients usually present with refractory ventricular fibrillation. Refractory ventricular fibrillation is basically the failure to achieve ROSC even after giving 3 defibrillation shocks. In these cases, there will be a poor prognosis. And usually, patients who are requiring more than 40 minutes of cardiopulmonary resuscitation, most of them do not survive. And most of these patients usually have an underlying coronary artery disease, which along with the poor perfusion during cardiopulmonary resuscitation. Essentially, cardiopulmonary resuscitation delivers only about 20% of the cardiac output. So poor perfusion with underlying coronary artery disease both render standard ACLS protocol ineffective. So the objective of this trial is, it is basically to compare survival to hospital discharge between 2 standards of care in our community after the patient has arrived at the hospital. So it is basically comparison between early ECMO facilitated resuscitation to emergency department based standard ACLS resuscitation. Coming to the study protocol, it is basically a phase 2 single center open label safety and efficacy randomized control trial. This trial is qualified for exception from informed consent under emergency circumstances. So participants who have enrolled for exception from informed consent, they were supposed to give written consent after awakening. Meanwhile, the research team will continue with the resuscitation by obtaining consent from the legally authorized representative. And both the patient as well as the legally authorized representatives, both were given a right to withdraw from the study at any point of time. Coming to the settings, this trial was conducted by the Cardiovascular Division of the University of Minnesota in collaboration with 3 emergency medical service systems. And the trial period was between August 2019 to June 2020. Coming to the patient population, the criteria under which patients were selected were usually adult patients in the age group of 18 to 75 years, and patients who had an initial out-of-hospital cardiac arrest with initial rhythm of ventricular fibrillation or pulseless ventricular tachycardia, and patients in which ROSC was not achieved even after 3 defibrillation shocks. If sustained ROSC is achieved after 2 defibrillation shocks, such patients were excluded from the trial. And patients whose body morphology was able to accommodate Lund University Cardiopulmonary Assist System, also known as LUCAS, that is a mechanical CPR. And estimated time of transport to the emergency department should be within half an hour. All these patients were included in the criteria. Coming to exclusion criteria, patients who do not have a valid do not resuscitate orders, patients with blunt or penetrating trauma, burn-related injuries, known poisonings, known overdose, known pregnancy, terminal stages of cancer, and who are on palliative care, and patients who have absolute contraindications to emergent angiography, patients who have known allergies to contrast, patients who have active GI or internal bleeding, and in institutes where there was no availability of catheterization laboratory, all these patients were excluded from the trial. Coming to the trial profile, initially 36 patients were assessed for the eligibility, but out of this, 6 patients were found to be ineligible because in 2 patients, the initial rhythm after out-of-hospital cardiac arrest was found to be a PEA. And in 1 person, the transfer time to the emergency department turned out to be more than 30 minutes. And in 3 patients, ROSC was achieved after second defibrillation shock. So all these 6 patients were eliminated from the study. Then 30 patients were randomly assigned into 2 different groups. So 15 patients assigned to the standard ACLS treatment and 15 patients into the early ECMO facilitated resuscitation group. In patients assigned to ECMO facilitated resuscitation group, one patient withdrew from the trial on day 3. So there were 14 patients in the ECMO facilitated resuscitation group, while there were 15 patients who underwent the trial in standard ACLS treatment group. Coming to the method of randomization. On hospital arrival, one research member of the study team, they had verified eligibility, and then the randomization is computer generated. It is basically using permuted blocks with randomly varying block sizes of 2, 4, and 6. This computer generated randomization using permuted blocks, it basically was to ensure approximate balance between the 2 groups and initial equal probability of assignment to the either of the groups. Coming to masking, emergency teams, they were masked to all aspects of the trial, while the critical care teams, they were masked to group allocation. And the outcome assessment, usually at the time of hospital discharge and at 3 and 6 months post-discharge, this assessment was done by qualified evaluators who were masked to group allocation. Coming to the intervention or procedures done in the respective groups. In patients who were allocated to the ECMO group, they were shifted to cardiac catheterization laboratory immediately after arrival to the hospital, irrespective of the presence or absence of pulse on hospital arrival. And after shifting the patient to the cardiac catheterization laboratory, cardiopulmonary resuscitation is being underwent, and during that time, arterial blood gas analysis sample was obtained in all those patients. Resuscitation discontinuation criteria. Based on the arterial blood gas analysis report, if the end tidal carbon dioxide, it is less than 10 mmHg, or PaO2 less than 50 mmHg or oxygen saturation less than 85% and lactic acid levels more than 18 millimole per liter. If either two or more than two of the following criteria are met, in such cases, resuscitation efforts will be terminated and patient was declared dead. And if one of the above criteria or none of the above criteria is met, then patient was initiated on VA ECMO support, followed by angiography plus or minus revascularization of the culprit vessel was done. Coming to standard ACLS resuscitation group. In this group, patients were treated in the emergency department under the care of emergency physicians. The protocol suggested that standard ACLS resuscitation in this group, it should be continued for at least 15 minutes after arrival to the emergency department or at least 60 minutes after the announcement of 911 call. So after this, if patient did not achieve ROSC despite the above protocol, whether to continue further resuscitation or to declare death, it was at the ER physician's discretion. And if ROSC was achieved, such patients were shifted for angiography. Coming to the management that is common to both the groups. Post angiography and revascularization, both the group of patients were kept in cardiac intensive care unit under the leadership of cardiac critical care teams. The management that was being done is therapeutic hypothermia, that is target of 34 degrees centigrade for 24 hours, minimization of vasopressor support with optimization of ECMO flow, and no neuroprognostication for at least 72 hours after cardiac arrest, and CT brain to be done on the day of arrival and at day 3, and continuous EEG monitoring until awakening. This is the management that is common to both the groups. Coming to outcomes assessment. The main aim of this study, that is the primary outcome assessment, is survival to hospital discharge between these two groups. And the secondary outcomes that are being studied are survival and functionally favorable status, which was assessed at hospital discharge and at 3rd and 6 months after hospital discharge. This was basically assessed using 2 scoring systems. One is the modified Rankin score, and the score ranges from 0 to 6, where 0 indicates the patient was relatively asymptomatic and 6 indicates death. Score of less than or equal to 3, which suggests favorable outcomes. And the other score is cerebral performance category scale. This scale ranges from 1 to 5, where score of 1 indicates good cerebral performance and score of 5 indicates brain death. So a scale of less than or equal to 2 of cerebral performance category scale suggests favorable outcome. And also all the adverse events during the trial were recorded in secondary outcomes. Coming to the statistical methods. This study basically used a hybrid design of Bayesian and frequent statistical analysis. Initially, randomization was done for 30 patients in 1:1 ratio. This is to ensure approximate balance between the groups and equal chance of eligibility into both the groups. So, using this hybrid design, outcomes are studied after every 30 participants, and initial 30 participants are based on 1:1 ratio. Then subsequent Bayesian analysis, which was conducted for every 30 patients, this will determine ratios based on posterior probabilities generated. That is, if suppose the posterior probability that ECMO is better than ACLS is 0.58, and the posterior probability that ACLS is better than ECMO is 0.42, then the next 30 patients will be randomized based on the posterior probability scores in a ratio of 58:42. The main advantage with this Bayesian analysis is this will prevent too many patients from getting an inferior treatment. Since subsequent analysis, most of the patients will be redirected to superior treatment strategies. And then there will be a data safety and monitoring board which alerted if any of these reviews, the posterior probability is more than 0.986, then it will suggest to conclude the trial, since the efficacy of one group is much better than the other. Coming to the results, as we have already discussed the trial profile, 14 patients were in the ECMO facilitated resuscitation group and 15 patients were in the standard ACLS treatment group. Out of these groups, primary outcome, survival to hospital discharge, was 6 out of 14 patients in early ECMO resuscitation group had a good survival to hospital discharge, while 1 out of 15 patients in standard ACLS treatment group got discharged. Coming to secondary outcomes, cumulative survival significantly was better with the ECMO than with standard ACLS treatment at hospital discharge. But secondary outcomes couldn't be compared between both the groups because the only patient who survived in the standard ACLS group, that patient died before 3 months of assessment. This is a graph representing primary and secondary outcomes. And while randomizing the groups, baseline characteristics were similar between both the groups. And the average duration of CPR from 911 call to death was approximately 81 minutes in standard ACLS resuscitation group. And the time from 911 call to VA ECMO initiation was approximately 59 minutes in the early ECMO resuscitation group. And the time from randomization to VA ECMO initiation was only 12 minutes in the ECMO resuscitation group, which favored good outcomes. Coming to the adverse events that were being studied in the trial. As it is very common with ECMO, multi-organ failure is one of the major adverse events that were encountered, but all the patients survived and improved over a period of time. Coming to device-related events, ECMO device-related events, cracked tubing connector was observed in only one of the patients and it was replaced. Access site bleeding, which was requiring transfusion of more than 3 units of PRBC, it was observed in 2 patients who underwent ECMO facilitated resuscitation. And the other common adverse effects were cerebral edema, rib fractures, liver failure, renal failure, and respiratory events. Coming to the strengths of the study. It was a randomized control trial, so selection bias was minimized. And the other advantage was short duration of time from randomization to ECMO initiation. As we already discussed, it was around 12 minutes. And all these patients and all this study was analyzed based on an intention to treat principle. Device-related adverse events were also low. And since they have applied Bayesian group of statistics in this design study, it ensured that more number of patients were receiving effective treatment. And the trial results were similar to many other trials involving ECMO. Coming to the limitations of the study, it was a single center study, so it reduced external validity. This would have been followed by a multi-center RCT trial. And the center in which this trial was done, it has a highly experienced critical care cardiology team and similar local emergency teams expertise also. So this might not be possible in other places. And the trial was conducted on a small number of patients due to the resources and requirements. And cost analysis of the trial was also not done. Cerebral performance category scores of less than or equal to 2 were considered fine, but there would be a significant difference in the quality of life between score 1 and 2 also. So breakdown of scores would have been done. Coming to the conclusion, this trial suggests that early ECMO facilitated resuscitation for patients with out-of-hospital cardiac arrest and refractory ventricular fibrillation significantly improved survival to hospital discharge and functional status compared to patients who have received standard ACLS resuscitation. Thank you.
Yeah, thank you, Dr. Pooja. It's a nice presentation from your side. We have small questions about it. Is there any pediatric age groups are involved in this trial?
No, sir. 18 to 75-year-old were involved in the trials.
Okay. What about this unwitnessed cardiac arrest? It's like they have consideration any those unwitnessed cardiac arrest in these cases?
Yes, sir. Basically out of hospital cardiac arrest, even with bystander CPR also.
Okay. It's like how much long this calculation was made? It's like a patient reached to the hospital for how much time the monitoring was done for this patient? It's like 1 month or 15 days, this observation of the patient.
Patient was shifted from out of hospital to emergency department within 30 minutes, sir.
Okay.
And the monitoring was based on the survival of the patient. Average length of ICU stay in ECMO patients was 21 days.
Okay.
And average length of hospitals and whole hospital stay for ECMO patients was 25 days.
Okay. So as per you, it's like early ECMO representation is how much percentage is of benefit out of 100%?
98%.
98%. Okay. Dr. Kiran sir, do you have any questions from your side?
Yeah, Halim.
Yes, sir.
So Pooja, that was nice presentation.
Thank you.
Okay. So per se, no questions. I think you might have asked, no? So you have covered majority of the things. Okay. So we'll take in the end of the session, if any. Okay.
Okay. And second presentation is by Dr. Divya. Divya, are you there? Yeah, Dr. Divya is presenting a PROG trial or the same concept, but small difference is there. The Divya will explain the situations of this PROG trial. Okay. Divya, you joined right.
Good evening, everyone. Sir, can you hear me, sir?
Yes.
Today we are going to discuss about PROG trial. The main objective of this trial is to determine whether an early invasive approach in adults with refractory out-of-hospital cardiac arrest improves neurologically favorable survival. Coming to study designs, it is a single-center randomized clinical trial which was conducted from March 1st, 2013 to October 25th, 2020, with final follow-up on March 30, 2021. This study actually compared two different treatment strategies. The first one is an invasive strategy. It is a bundle of early transport to hospital using mechanical CPR, ECPR, and immediate invasive evaluation and treatment to standard strategy in refractory out-of-hospital cardiac arrest. The enrollment was conducted with the close cooperation of Prague Emergency Medical Service Dispatch Center. In this, the study coordinator will receive automated SMS when ambulance is dispatched and telephone-assisted chest compressions is initiated. Once physician or paramedic is on scene, then telephone connection is established to allow randomization. The randomization is via web-based system. Coming to the participants, aged around 16 to 85 years, receiving ongoing resuscitation for witnessed out-of-hospital cardiac arrest of presumed cardiac etiology were eligible for enrollment in this trial. Given that they have received minimum of 5 minutes of advanced cardiac life support performed by emergency medical service team without sustained return of spontaneous circulation, unconsciousness, GCS of less than 8, extracorporeal life support team, and invasive care unit bed capacity in cardiac center available. The exclusion criteria in this trial is out of hospital cardiac arrest of presumed non-cardiac cause, unwitnessed collapse, suspected or confirmed pregnancy, return of spontaneous circulation within 5 minutes of advanced cardiac life support performed by emergency medical service team, conscious patient, known bleeding diathesis or suspected or confirmed acute or recent intracranial bleeding, suspected or confirmed acute stroke, known severe chronic organ dysfunction or other limitations in therapy, do not resuscitate order, or other circumstances making 180-day survival unlikely, known pre-arrest cerebral performance category, that is CPC, more than or equal to 3. Coming to methods, the randomization, the patient's estimated age and sex, as well as confirmation of the inclusion and exclusion criteria were recorded. Randomization into the stranded group or into the invasive group was based on 4 strata. That is, men's more than age more than 45 years or less than 45 years, women age more than 45 years or less than 45 years, with block size of 8. The block size was not disclosed to research personnel. In Prague, there are 4,387 patients in Prague, there are 4,345 patients with out-of-hospital cardiac arrest assessed for eligibility. In this, 358 without return of spontaneous circulation assessed for inclusion. In the 358, 264 were randomized. 7 patients were excluded after randomization because consent was refused and information was not available as to how many were randomized to each group for analysis. 124 patients were randomized to invasive strategies and 132 patients were randomized to the standard groups. There are crossovers. 9 patients were crossed over to standard groups and 11 patients received crossover to invasive strategies. Standard strategy group. Patients randomized to the standard strategy group received continuous advanced cardiac life support on site. The use of drugs, further defibrillations or other interventions followed recommended guidelines. If ROSC was achieved, transport to the hospital was initiated and early invasive strategy, example coronary angiography, was encouraged. Invasive strategy group, intra-arrest patients was immediately transferred directly to the cardiac center catheterization laboratory during ongoing CPR with the initiation of proceeding with eCPR if ROSC was not achieved en route or on admission. The use of drugs, defibrillations or other interventions during transport followed European Resuscitation Council guidelines. The criteria for initiation of ECLS, the inclusions are no return of spontaneous circulation or return of spontaneous circulation with ongoing shock, defined as sustained hypotension below 90 mmHg of systolic pressure or need for moderate to high doses of vasopressors. Admission to cath lab not later than 60 minutes after collapse or initial call to emergency medical service. Consents of cardiac center team members on extracorporeal life support initiation. The exclusion criteria was signs of death or irreversible organ damage, known bleeding diathesis, inadequate arterial or venous access for femoral cannulation. Interventions. On admission, the overall status, the presence of ROSC and ECLS implantation, inclusion and exclusion criteria were evaluated. The ECLS cannulation was performed on the catheterization table during ongoing mechanical CPR using a femoral approach. After commencement of ECLS and the following, the completion of the invasive diagnostics and therapeutic procedures like coronary and eventually pulmonary or aortic angiography and PCI, that is percutaneous coronary intervention if appropriate. An antegrade perfusion cannula was implanted in the cannulated limb under using ultrasound guidance. Patients receiving ECLS were continuously anticoagulated with heparin unless contraindicated, with a target of activated partial thromboplastin time of 50 to 70 seconds. Post-resuscitation care standardized in both groups. Urgent transthoracic echocardiography and whole body CT if feasible and indicated. Target temperature management in hospital. The target temperature management was maintained at around 33 degrees centigrade. In cases with early awakening or complications of hypothermia, a strict target temperature management of 36 degrees centigrade were allowed instead of 33 degrees. All other treatments, including withdrawal, complied with European Council resuscitation guidelines. The crossovers were allowed from standard to the invasive strategy based on the request by the emergency physician. At least 2 additional unsuccessful defibrillations were required. From invasive group to standard groups, allowed if continuing invasive measures were deemed to be futile. Exploratory analysis. The survival to 180 days was assessed as a post hoc outcome. Post hoc subgroup analysis for the primary outcome were performed in the following subgroups: older than 65 years versus 65 years or younger, sex, place of cardiac arrest, initial rhythm, pH below median value versus above, lactates value below median values versus above, cause of cardiac arrest. The power calculations was based on 10% favorable survival in standard groups. 3 scenarios for increased rates of favorable survival in invasive groups were calculated. 10% increase of primary outcome required 571 patients, 15% increase of primary outcome required 285 patients, 20% increase of primary outcome required 176 patients. A complete statistical analysis, a complete case analysis with no assumptions made for missing data was performed for primary and secondary outcomes. In the main analysis, patients' data were analyzed according to the randomization group, and data from patients who crossed over were analyzed by original group assignment. A post hoc analysis pooled all patients treated with ECPR, both those allocated to the invasive strategy group and receiving ECPR, and those allocated to the standard groups and receiving ECPR after crossover to the invasive strategy groups. The continuous data were evaluated for a normal distribution by Shapiro-Wilk test. The 2-sided Mann-Whitney test were used to compare cardiac arrest times and laboratory values. The primary and secondary outcomes are reported by odds ratios and absolute difference with 95% confidence intervals. The survival analysis was performed by the Kaplan-Meier analysis and log rank test and considered patients alive at 180 days regardless of their neurologic status. Because of the potential for type 1 errors due to multiple comparisons, findings for secondary outcomes and subgroup analysis should be interpreted as exploratory. A 2-sided p-value of less than 0.05 were considered statistically significant. Results. The study was terminated on October 25, 2020 at the recommendation of Data and Safety Monitoring Board because the standardized test statistics for results of primary endpoint in the study intersected a specified stopping rule for futility, that is null hypothesis equal to 256. Coming to the results, the comparison between invasive group and standard groups. The median age in invasive group is 59 when compared to 57 in standard groups. Male 82 versus 83%. The location of arrest mostly in home, that is 34% in invasive group, and in standard group it is 26%. Initial rhythms Mostly it is shockable rhythm that is VF in 58% in invasive group and 64% in standard groups. The second reason is PEA, 17% in invasive and 18% in standard groups. The third is asystole, 25% in invasive and 18% in standard groups. The bystander CPR is most or like equally in both groups. Mechanical CPR, it is 92% in invasive group and 79% in standard groups. The pre-hospital adrenaline doses, the median was 4 versus 5, and pre-hospital defibrillation attempts, median was 4 in invasive and 4 in standard groups. Pre-hospital declaration of death is more in standard groups, that is 34%, and in invasive it is 1%. ECLS, 66% in invasive groups were cannulated with the femoral approach and 88% were in standard groups. The time to ECLS median was 61 minutes in invasive and 62 minutes in standard groups. The door to ECLS is 12 minutes in invasive and 16 minutes in standard groups. The cause of arrest, which includes autopsy findings, the most common is ACS, acute coronary syndromes, that is 52% in invasive and 48% in standard groups. The second is pulmonary embolism and third is myocarditis. Coming to outcomes. The primary outcome, it is a 180-day survival with minimal or no neurological impairment, that is CPC should be 1 or 2. The cerebral performance category screen ranges from 1 to 5. CPC 1 defined as conscious, alert and able to work, whereas CPC 5 defined as brain death. All patients were observed to death or 180 days. In invasive group, the primary outcome is 32% when compared to standard group, the percentage 22% with absolute difference of 9.5. Coming to secondary outcomes, it is a 30-day survival with minimal or no neurological impairment along with cardiac recovery at 30 days. In invasive group, the cardiac recovery is 43%, whereas in standard group, it is 34% with absolute difference of 9.4%. The neurological recovery in secondary outcome in invasive groups are 30%, and in standard groups, it is 18%. With absolute difference of 12.4%. The diagnostic angiography is more in invasive groups than in standard groups. The lab values, pH is 6.93 in invasive group and in standard it is 7.03. Lactates 12.5 in invasive and 10.4 in standard groups. Death is more in invasive group when compared to standard groups. Withdrawal of sustaining life therapies is more in invasive groups, and accepted for organ donation is more in invasive groups when compared to standard groups. Complications. Bleeding complications were assessed based on thrombolysis in myocardial infarction, classified under major category, defined as any intracranial hemorrhage excluding microhemorrhages of less than 10 mm. In invasive group, it is there are more bleeding complications, 31%, and in standard group, it is 15%. Fatal bleeding directly resulting in brain death within 7 days, or overt bleeding associated with decrease in hemoglobin concentration of 5 grams per deciliter or 15% absolute decrease in hematocrit. Organ lacerations were assessed both by morphological examinations, mainly CT, and during autopsies. Technical complications related to ECLS were gathered and reported by perfusionists. Considering wide confidence intervals in between group difference for primary outcome, the study may have been underpowered to detect a clinical important difference in the favor of the invasive strategy group. In the predefined secondary outcome analysis, a significantly improved 30-day neurological recovery defined as CPC 1 or 2 was shown in favor of invasive strategy, in contrast to cardiac recovery, which was not statistically different between the groups. Invasive approach was associated with increased risk of bleeding, complications, and inherent complication of eCPR. In this study, the patients were evaluated during ongoing CPR, whereas in other studies, potential candidates were evaluated retrospectively. In this study, the timeline was adhered to match the timeline as planned in the protocol and probably request a realistic timeline in semi-crowded urban areas using in-hospital eCPR for out-of-hospital cardiac arrest. Patients were admitted within a median of 49 minutes of collapse in the invasive strategy group, representing approximately 26 minutes of retrieval and transport from the scene to the hospital. The overall pooled neurological favorable survival at 180 days of 27%, in the 31% in invasive strategy and 22% in standard strategy group and 22% in the pooled eCPR group is comparable to that in other non-randomized studies evaluating eCPR. Studies of refractory out-of-hospital cardiac arrest treated by eCPR inherently addresses potential organ donation. Potential donors were frequently considered and organ donations occurred. This study has several limitations. The study had a single center design and limited enrollment. A prior scenarios of expected benefit provided by invasive approach were not reached, presumably because of higher than expected survival in the standard strategy group. The study may have thus been underpowered to detect a statistically significant difference for the primary outcome. The study design allowed crossover. Conclusion: among patients with refractory out-of-hospital cardiac arrest, the bundle of early intra-arrest transport, eCPR, and invasive assessment and treatment did not significantly improve survival with neurologically favorable outcome at 180 days compared with standard resuscitation. Thank you.
Thank you, Dr. Divya, for giving a good presentation over here. Okay. It's like Kiran sir, do you have any questions from your side?
Yeah, one question. One question to Divya. Divya, in your study, door to EC less time. In invasive group, it's about 12 minutes, right? In standard, 16 minutes. In standard group. So what made the difference? What do you think? What made the difference between these two? Door to EC less time.
Actually, sir, what happened is in invasive standard groups, they have used ongoing CPR. Along with there should be a bed availability in the cardiac center so that it will take time to transport to cardiac, and cardiac on-call doctor should be available.
So overall, there is no difference between invasive group and standard therapy group, right?
Yes, sir.
Okay, good now. Okay, that's it.
And coming to the next presentation, is Dr. Akshaya.
Yes, sir. Sure.
Yeah. Start your session, please.
I'm sharing the screen. Is it visible, sir?
Yeah, visible.
So now we'll discuss about the next trial. Actually, in the preset, we already have two trials which are analyzing the use of early initiation of ECMO during cardiac arrest. So this study is the INCEPTION trial. So we all know that ventricular arrhythmias are the major cause of out-of-hospital cardiac arrest, among which the shockable rhythms have better outcome. And also the outcome, chances of good outcome decreases with increased time of CPR. So in this preset, extracorporeal CPR can be tried, which improves the cerebral perfusion and limits the hypoxic brain injury. So this is the reason why eCPR has been tried over the last few years. So this is the timeline of the major trials of ECMO in CPR, ARREST trial, PRAGUE trial, and the INCEPTION trial, which is the latest trial. So the research question in the INCEPTION trial is, in patients with refractory out-of-hospital cardiac arrest and initial ventricular rhythm, does ECMO added to the CPR compared with conventional CPR improve the survival and favorable neurological outcome? So we already know that out-of-hospital cardiac arrest remains a major public health problem with an extremely high mortality rate. So refractory cardiac arrest is defined as cardiac arrest that lasts more than 15 minutes despite resuscitative efforts. eCPR is a salvage procedure in which extracorporeal membrane oxygenation or ECMO is initiated emergently on patients who have had cardiac arrest and on whom conventional CPR has failed. So in this study, the methods are, the study design, it is a multi-center randomized unblinded parallel group investigator-initiated clinical trial. This is unlike the other two trials, which are single center based trials. And the study setting was the 10 cardiosurgical centers and 12 emergency medical services in Netherlands. Time period was between 2017 May and February 2021. So the patients, the inclusion and exclusion criteria were defined. The inclusion criteria included out-of-hospital cardiac arrest patients which were witnessed, and 18 to 70-year-old, and those who had a shockable initial rhythm and who were refractory only after the initial 15 minutes of standard ACLS treatment. Exclusion criteria involved those who had a ROS attained before the 15 minutes and those having severe pulmonary disease, severe malignancy, or any suspected pregnancy or any contraindications for eCPR, including femoral bypass surgery, and other expected interval of more than 60 minutes to the initiation of the ECMO procedure. And further, it also included already severely neurologically debilitated patients with a severe neurological disability score of 3 or 4 and severe injury scale and known terminal heart failure. So in our study, the intervention is the extracorporeal CPR, which means ECMO started in addition to the ongoing conventional CPR after initial 15 minutes of standard ACLS. And this was initiated by a qualified physician via bifemoral approach. So the control group here is a group with a conventional CPR as per the ACLS protocol. And this CPR was continued until ROS attained or until declaration of death. So outcomes were assessed as primary outcome and secondary outcome. Primary outcome was the survival with favorable neurological outcome, as mentioned earlier, at 30 days. And these analyses were performed on an intention to treat basis. Intention to treat basis, which means that other than the initially excluded patients, all the patients who gets excluded on the way of a trial are also included, so that it is more of a practically applicable trial. So secondary outcomes include 3-month and 6-month survival with favorable neurological outcome and also the admission to ICU. So statistical analysis, this trial has an adaptive design, which is based on a pre-planned interim analysis. So the number of sample size and number of patients involved were modified throughout the procedure. And the investigators were initially unaware of the trial group assignments, and later at the later stages, but blinding couldn't be continued. Analysis was performed on intention to treat basis. So all the patients, regardless of the outcome, were involved in the analysis. And the data were divided as categorical and continuous variables. Continuous variables were calculated with standard deviation. And the categorical data were represented in numbers and percentages. And the correlation was established to analyze the survival with the CPC score, which is 1 or 2 is the favorable outcome, which means minimal neurological disability or no neurological disability at 30 days, 3 months, and 6-month period. So this is the study outline. So the initially it started at the witness out of hospital cardiac arrest event. From there, then the once the EMS is arrived And once they assess the initial exclusion criteria meeting, people are excluded from the study. And from then, the remaining people who are admitted to the hospital are divided into two equally. This was done based on permuted block randomization. So at the level of hospital admission, they were divided with randomization, and one group was subjected to conventional CPR and the other group underwent the eCPR. So among them, those in whom ECMO couldn't be initiated were excluded, and where ROS was attained before ECMO started were also excluded, but then they were also included in the final analysis. And then the two groups with eCPR and conventional CPR, both were given same post-CPR care. And from then on, after ICU admission, their outcomes were assessed at 30-day interval, 3-month and 6-month intervals. So initially, there were 160 patients who underwent randomization. And after randomization, 26 were excluded. This was based on the exclusion criteria where ROS were attained earlier or unwitnessed, or the age was out of the criteria. And finally, 134 were included in the intention to treat population. Among the 134, 70 were assigned to eCPR group and 64 were assigned to receive the conventional CPR. So among them, not all could complete the eCPR treatment, as 13 had attained ROS before the ED itself, and there were logistic failure in 3, and 2 had to stop treatment before the eCPR. And in the eCPR group, 70 were included in follow-up, and all the 70 were included in primary analysis also, regardless that not all were continued in eCPR. So in the conventional group, all the 64, among them, 9 had ROS before ED and 3 had extracorporeal CPR. Despite assignment to the conventional CPR, they were finally turned to eCPR. So regardless of this, all the 64 were analyzed and followed up in primary analysis. So our results, the primary outcome is that there is no significant difference in the survival with a favorable neurological outcome, which is defined as cerebral performance category score of 1 or 2. 1 or 2, which means it is either a normal neurological outcome or minimal neurological disability without impairing daily activities. So this is at the 30-day interval. And secondary outcome is 3-month and 6-month survival, which also showed no significant difference. Among the ICU admission in the eCPR group, it was found to be more. And the discontinuation of treatment due to multiple organ failure and neurological unfavorable outcome were more in the ECMO group. So these were the adverse events which were encountered during the study. So compared to the conventional CPR, the adverse events were more in the extracorporeal CPR, which included major bleeding, post-anoxic encephalopathy, limb ischemia, and ECMO circulation failure. So this is the final table with complete outcome analysis. So it clearly shows that the initiation of the eCPR, it was done in 52 patients, and among them, there were failed cannulation in 6 patients, and there were death of 2 patients, and so it was successful in 46 patients. So in the other group, it was 61, it was continued as such. And the ROS was attained in a similar numbers, 18/70 and 20/64, and the other excluded category. And in this, the ICU stay, it shows more in the eCPR group, which is 58 compared to 24 in the conventional CPR group. ICU admission and hospitalization were more in the eCPR group. And the death after ICU admission also in follow-up, it was more in the eCPR group. And the discontinuation of treatment due to multiple organ failure, cannulation failure, ECLS failure, and neurological unfavorable outcomes were more in the eCPR group. So this is the primary outcome. This shows the primary outcome survival, 30-day survival, which shows that there is no much difference. And the odds ratio is 1.4, but the p-value is non-significant. The secondary outcomes at 3-month and 6-month were also comparable, not statistically significant. And this is the cerebral performance category score based on which all the previous 3 trials were done. So CPC1, which means that there is good perfusion or good cerebral performance. That means patient is completely conscious, alert. There is normal neurological function. And CPC2 is where there is moderate disability. The patient is conscient and able to perform daily activities independently. CPC 3, 4, and 5 is the complete brain death. 3, 4 are severe disability, with 4 being coma or vegetative state. So this is the graph showing the outcome. It clearly shows that in the primary outcome, there are like it's slightly 14 number compared to the 10 of the conventional CPR had better neurological outcome, but still it is not statistically significant. And at 6 months, and we have a similar picture. Also, comparing the serious adverse events at the end, it is more in the extracorporeal CPR group. So basically, among the previous 2 trials, the ARREST trial, it had included 30 patients, and similarly, VT and VF initial rhythm were involved, and it showed improved outcome with eCPR, and there was early initiation of eCPR in the group. And this study was stopped early due to benefit, but this also has a limitation that it was a single center study and it had a small sample size. Next, we have the PRAGUE OHCA trial, which included more number of patients, and it also included the PEA category people during initial rhythm. And in that, there was a good neurological outcome at day 180, but this study was also stopped early due to futility, and it was also a single center study. So compared to the previous 2 trials, in this study, the significance is that there is both internal validity and external generalizability. External generalizability is because it is a multi-center study and it covered multiple metropolitan sites in the Netherlands. And it enrolled the actual population as they were set out to investigate, which included the younger witness, VT, VF patients, and also the refractory cardiac arrest population. Internal validity is also established as the initial baseline demographic factors were well balanced and matching was done, and there were minimal loss to follow up, and there was an interim analysis and a published statistical analysis plan, and the whole procedure was done on an intention to treat basis. Limitations of the study include already defined by the authors are the time early randomization led to large number of patients who had ROS before ECLS, which may have affected the ability to detect the effect from treatment. And there was also a lack of standardized protocol for eCPR. During this study, the eCPR protocols were followed as per the individual institutional guidelines. There wasn't any standardized protocol. So other limitations are, there is large variation in cannulation times. And this was also because the different centers had different expertise level in ECMO and procedures, but this was not taken into consideration. Some participating centers were just in the initial stages of their eCPR program, and they were still participating in the trial. So that is important because experience of the center will impact the outcome, since the time to cannulation is considerably prolonged in this group. So ARREST and PRAGUE trials took place in experienced single centers, and that could also explain their positive outcomes. Whereas this was done in a multi-center and at variable level of ECMO expertise. So basically the summary is that INCEPTION trial is the first multi-center and randomized control trial which explores eCPR in patients with refractory out of the hospital cardiac arrest, presenting with pulseless VT and VF initial rhythm. And this aimed to determine the effect of eCPR on survival rate and neurological outcome at the end of 30 days, 3 months, and 6 months. And also it evaluates the feasibility and cost effectiveness. And this is a pragmatic randomized control trial, and hence all the people who were excluded during the trial were also included in the analysis, and it's more of a practically applicable approach. So final take-home points are eCPR for OHCA with prolonged flow times does not significantly improve neurological outcome as per the final analysis. However, this ECPR is a complex system-based intervention where many other factors other than ECMO also drives the outcomes, and that also impacts the final neurological outcome of the patient. So those also need to be considered while doing further study. And further research needs to be done to define the optimal system that can deliver effective ECPR which is reproducible and it being a cost-effective intervention. Thank you.
Aleem, unmute yourself.
Yeah, thank you, Dr. Akshaya, for wonderful presentation. Okay, as per your trial, what is the benefit compared to previous trials you are observed?
The main thing is that it's a multi-center approach.
Great. And also it's conducted in large number of populations, right?
Yes.
Okay. It's like after this trials, is there any new trials also came, or this is the last trial which is performed on the cardiac events?
There was another trial, but it was also stopped halfway.
Okay.
Yeah, no, you can talk, Akshaya.
Okay.
Announcement.
Yes, sir. There was like another trial before this inception trial, but it couldn't be continued. It was stopped halfway. And after the trial, after the inception trial, I am not aware of any other studies.
Okay, good. And as per you, after these 3 trials, so what is the advantage of it's like invasive procedure is superior compared to normal randomized ACLS protocols? Is there any superior event is there, or almost same only?
So, like as concluded by this trial, superiority as such couldn't be established, but still it is a very possible, like it is a very good intervention, like for the feasibility for which need to be researched in the future.
Okay.
Like expertise is very variable and it is there in very less number of centers. So considering all that factors, if further research is done.
Okay, okay. Kiran sir, from your side, any questions is there?
Akshaya,
Yes,
so in your trial, inception trial,
yes.
it's regarding exclusion criteria. So why bilateral femoral bypass surgery case were excluded?
Because in this we are using the VA ECMO, and mostly the approach, the approach here used is the femoral approach.
Oh, that is one thing. Then when it comes to CPC score,
Yes, sir.
so which groups better? Which one is better? Whether it is ECPR group or conventional group?
Actually, it was comparable. In the outcome, it was comparable. The CPC, it was divided as good outcome and worse outcome. So good outcome in CPC 1 and 2, the initial category. It was similar in both the groups. And that is the primary outcome of the trial.
So not much of difference at all.
Not much difference.
Not much difference.
Number is 1 or 2 higher in the ECPR group, but not
The
statistics.
difference of numbers when compared both the groups, like 3 or 4. But when you see the p-value, it is
Yeah,
insignificant.
it is not significant. Yes.
So it doesn't make any difference at all. So whether you do ECPR or you don't do it, so it doesn't make any difference. So this is the timeline as of now. So hopefully we'll get better results in the future. So with the advancement of technology, then advancement of all these things, no? So I think we can expect better results with the ECPR. Aleem, do you want to add anything here?
No, sir. That's is sufficiently she's presented here, sir. Naveen sir, from your side, anything point to add on?
No, that's it. As Kiran summarized, we need much more research into this, and many more studies are required. So I think if there are no more questions, we can end the session.
Yeah.
Thank you to those 3 units for participating. We'll be ending the session. Thank you.
Thank you. Thank you.
Thanks.